Lots of people are familiar with the idea that since COVID, during COVID, demand for mental health impact on everyone's mental health, but children, adults, everybody really struggled. And certainly being in children's mental health services through COVID and after COVID, you could really feel the increase in demand. And if you look at the data, it totally tracks those patterns in terms of significant spike. Lots of CAMHS teams and other services actually closed waiting lists early on in COVID, but then lots of things reopened, and when schools went back and lockdowns lifted, the demand then really came out. And certainly working in services at the time, we were hearing a lot as well, probably after the first lockdown or two, and then it was a pretty consistent pattern for a couple of years, and until now I'd say like acuity really went up, so how poorly young people were was noticeably different than before COVID. And it's that classic stuff, we're 5-6 years on, but it's had a significant impact on young people. Not only I certainly see a lot more OCD than I ever used to see in young people, but the other areas that went up with schools closing, I think it really hit a lot of children's social skills and transitions and adapting. So that was huge, being off school as much as the pandemic. I think it was being off school had a huge impact.
Also, there's reduction in baby groups and baby socialising as well. It wasn't just schools, it was the right from birth stuff. Yeah.
And I'm sure we all know friends and contacts who had babies in COVID and in lockdowns. And certainly my friends that did had a very different experience to those of us that didn't have children and have babies in that period. The other thing that we really noticed in services was a huge spike in young people presenting with autism and struggling with anxiety related to autism. And I don't know if there's something about those young people would have had autism anyway. The COVID pandemic certainly wouldn't have caused that developmental problem, but certainly the impact of COVID on people's coping skills certainly did. So we certainly saw a lot more young people coming forward requesting a diagnosis or requesting a support with autism, which wasn't particularly as strong a flavour before COVID. So the clinical presentation has shifted a bit with COVID, as well as the demand. The demand has gone up significantly.
Yeah, because the demand for MD assessments is also...
We've all seen it back, but waiting lists are huge now, whether that's for autism spectrum disorders or for ADHD, and we're talking years of waiting lists, not weeks or months. So pretty much any area that I've worked in or have come across, it is minimum a number of years now waiting for assessments, which is really difficult. And I think that's a combination, perhaps there's more awareness now of kind of neurodivergence and how that impacts on people, as well as perhaps with COVID and school lockdowns or closures, perhaps those symptoms have become more prominent than before. So people are now coming to ask for help that perhaps weren't needing it before. That's why waiting list numbers have gone up hugely.
The whole time they're on a waiting list, things are progressing, aren't they? Becoming worse, habits are being built, things are just escalating.
I think it's really difficult because service is still diagnostic led, so they're waiting, you wait until you get a diagnosis before you can get support, whereas it should really be the other way around. If you're truly needs led, which is what Thrive's all about, if we look at the Anna Freud, a lot of areas are now embracing that Thrive model of mental health and support. And actually it shouldn't be diagnostic led. If you need support, you should access support and the diagnosis comes later. But most services aren't truly structured or delivered in that fashion yet. Some areas are trying to, but it's really hard to get away from being diagnostic led. And then we end up with lots of young people waiting a really significant amount of time. Often those young people are just getting more and more poorly, or their symptoms are more impacted upon, and their families and their school performance or their life outside of school is just getting worse and worse.
Or in some cases not even attending school because anxiety is so profound that school is no longer an option.
We've seen, and it comes out in the data as well, there's been a significant increase in school avoidance and children struggling to get into school or stay in school. And I think there's definitely some theories around the impact of lack of support and lack of treatment, and therefore children staying home and parents are not sure what to do and how to cope and how to manage. So there's more children staying off and missing out not only on all that academic stuff, but also the social skills and the life skills and the contact with friends and other young people and all those good things that we know most of us are going to need in our life.
And even like basic behaviour learning, like following rules and routines and all of that stuff goes out the window, doesn't it?
Really important.
So,
And I think the managing waiting lists is something that I know a lot of services have, it's not a new problem. Services have been looking at how to reduce waiting lists for many years, but it's become more and more challenging as the waits have got longer. Certainly working in services last year in a particular system, there was real debate about, well, how do we manage our waiting list? What's the best way when we know our waits are over a year long? Ethically, that doesn't sit very nicely with any professionals or clinicians. That's not what anybody wants, but that is the state of the system. And it's about what other approaches could we use, what else could be done. I know there's often lots of moral and ethical debates about if our waiting list is a year for treatment, should we use some of our clinicians to offer some waiting well work, like some short-term brief interventions to people waiting on the waiting list. But then others will argue, well, actually that draws even more clinical resource away from the actual waiting list, and is it even going to get better? I know certainly some of the creative ideas that I've seen people try, whether they're digital approaches that we could use while people are waiting, and they're groups. There's really good evidence-based parent training and parent group training that could be done with minimal resource, either online or digitally, with digital products with a small number of clinicians, but does the benefit outweigh the resources it takes? I think it's a real live dilemma lots of services are having.
And in your experience of working with the teams you've been working, what's had most buy-in or most effect for the groups you've worked with?
I certainly think with a system I was working last year, we did a lot of work to go back to basics almost with the evidence base. So actually, given the diagnostic profile and the needs profile that we have across the services, so understanding what young people are waiting on your waiting list, so having a really good understanding of that and therefore what their needs are, and then looking at the evidence base, well, what should we be offering them, like what's likely to be effective? Because I certainly see in CAMHS teams where it's more for the moderate to severe end, you've got staff that have worked there often for a really long time and really passionate about what they do, but at times the workforce skills doesn't perhaps meet what we should be delivering in terms of evidence-based care. So there's been a big shift in more recent years towards things like CBT, parent training that I mentioned, newer approaches psychotherapy-wise, and I'm not sure that the workforce in all areas is caught up with that, so having enough people that can deliver CBT or having products that are CBT-based if you're thinking about OCD, for example. And of course CBT isn't a panacea, it doesn't work for everybody or all conditions, but having enough family therapists, for example, trained. So having a really good look at your workforce to make sure you can deliver the things that are likely to be effective has been really important.
And I guess getting effective treatment at the time the child needs it the most, and the ability to access it with parent support or whatever the caregiver is able to attend.
I think getting it at the right time that's the real challenge, right? It's often parents reach out. I'm sure there's been research about it, about the number of times parents reach out to get help before they actually get it. And it's not just the first phone call they've made, often they've made many attempts and they find the system very complicated in terms of where to go, who to go. Certainly as a professional in the area, I find the system really hard to navigate, and I'm a professional, I've worked in these services for a long time, let alone as a parent, how do you get support, who do you contact? So I think there's a lot to be done in terms of trying to simplify how you access help as a parent.
And how does that relate to the single point of access system?
So a number of areas have been trialling a single point of access. They've been going on for a few years now. I personally think it's a really good idea. So in theory it centralises all, so any referral to either a children's service or a children's mental health service in an area comes through one front door, so to speak. I've seen it work well where that's a multi-agency front door, so you might have mental health staff on that front door, sitting behind the front door, so to speak, as well as social care staff, perhaps some of your voluntary sector. So it's quite and they would do a brief assessment or a triage, but it's with all of the right organisations in the room who can check their systems, who can understand what the needs are, and they would then signpost the family or the child to the relevant service based on what their needs are. But I do think it simplifies how to access help. So if as a parent I want to get help for my child, I just go to that one place in the whole county and it's quite straightforward for me. Whereas in other areas that don't have a single point of access, and there might be 5 or 6 CAMHS teams, a number of the voluntary sector offering perhaps early intervention work, as well as all sorts of other social care teams doing interesting things like how would I know where to go as a parent? That's really challenging.
It's a minefield to even know where to start, and often parents are like you say, it's not the first phone call they've made. Often they're struggling with what they're dealing with at home or at school, or if they're home-based as well, not attending school.
And the research shows that parents and the child bounce around so many times before they get that treatment. So to your point about getting the right care at the right time, I think is really difficult for many families, and I think a lot say, well, no, they didn't. It took months, if not years, to get the right person who could help their child or help them manage their child. And all that time, many of these children are just getting more and more poorly. Their symptoms are having an increasing impact on their functioning, on their distress levels, on everybody's distress levels at home. I think it's a real challenge. The other thing I've seen work that's started to be piloted in several areas, following some of the learnings from the adult single point of access work, is having a digital front door. So there's a number of tools around that are trialling the use of a digital triage assessment like tool, which I think is a really interesting idea. It's clinician supported, so it's not AI led, that sounds really scary, generating lots of scary questions, but it's a tool that's been written by clinicians. It's sent out to a parent or the caregiver or a teacher to complete it on behalf of the child, to gather some basic information, and then it would populate that back into a single point of access system. So in terms of, it's attractive for a service because it reduces the amount of time that's needed to complete a clinical assessment. So certainly services I was working last year, it would on average take them three clinical hours to complete an assessment. That was often done over 2 or 3 sessions, which is quite a weighty amount of time when you've got huge workforce shortages, and it's quite a lot of time to take the child out of school and for a parent to bring them in, etc. Whereas if a lot of that basic information has been gathered initially, like school history, developmental history, etc., some basic psychometric measures perhaps, that can be all done by a parent at 10 o'clock at night while they're sitting in the kitchen with some downtime. That tool comes in with that information populated, and the clinician can read through, and then when they get to properly assess the young person, they know exactly what questions they're going in for, they've got the basics, and it can be a much more meaningful conversation. So I know some of the pilots are looking at engagement rates, completion rates, and having that clinician as part of that loop is vital, so it's not a standalone tool. But certainly the initial feedback that we were seeing in an area I was working last year was positive, and people were liking the tool. And so I think data will tell us over the next couple of years what mileage those sorts of tools have.
I guess it also helps the parent, doesn't it? Because they can fill it in a lot more detail, they can be really clear about what they're trying to get across, rather than in the assessment room where it probably feels quite pressured and trying to get the level of distress across to a clinician is probably quite difficult. So, well, that's really exciting.
Really, really valuable, I think, thinking about like how could digital tools not replace what the clinician's doing, but supplement or do some of the easier legwork that you don't need a clinician to do. Like a tool's really quick to do that. It's written by a clinician, it's robust, it's sound in terms of clinical detail, but actually it makes the process smoother. And then you can really save your clinical time and your resources for where it's going to have the most impact.
And for who needs it for that level of care, rather than a 3-hour assessment, or someone who may not need a 3-hour assessment.
Yeah, absolutely. And that's the other thing that's coming out of quite a lot of the data, I'm sure you've seen, but the waiting list problem that we've been talking about. NHS England was saying at the end of 2025, 550,000 young people waiting for treatment. Over half of those young people have been waiting over a year, so the data backs up these experiences we're talking about. But also an interesting angle that's coming out of the data is a lot of those young people, when they do have treatment, it's very short, so often there's a high percentage of young people that discharge after 1 contact. So there is quite a move nationally to be recording completion rates of treatment, and also how many contacts clinicians are doing per day, because certainly there's a huge administrative burden often with particular record systems, the amount of time that clinicians are putting into record keeping rather than actually treating the young people. There's a big shift to try and drive up actual clinical time, face-to-face time with a parent, with a child, or online time, but actually delivering treatments, acknowledging that balance doesn't seem quite right at the moment.
Yeah, because one of the things that we've been developing over the last few years has been like an ICBT treatment that children and parents can use at their own disposal. So they would see a clinician one-to-one, but they'd also access these tools and treatments outside of sessions. So hopefully making treatment a lot more accessible and in real time as well. Like you say, the parents at 10 o'clock at night, when they can access all of these things.
And certainly it's something that I've seen. We talked about young people waiting for ADHD or ASD assessments earlier and the long waits often that they endure. And I know some areas have really tried to look at what do we offer specifically for those young people, should we be offering things? And I think we should if people are kind of waiting for that long. But there are now there's some good parent training programs for young people, parents of children who are likely to have ADHD or ASD, and there's some good digital products coming out now. So I think that whilst you're waiting for that neuro assessment is really vital, as well as people talk a bit, who've family members, carers who've had experience in this area, talk a bit of a cliff edge. Actually, they waited 3 years for the diagnosis. They had their appointment that says, yes, your child has got autism or your child has got ADHD, and then they had nothing, and they sort of fall off a cliff edge with it. So that's the phrase people use, and you see it in the literature. And I think that's really difficult because it's not really provided that family with any skills to manage that young person. They've been given a diagnosis, but it's not really meeting the needs of that child. And you can see some systems trying to do differently now. So some places will offer post-diagnostic support, what does seem to be more effective when, as well as the diagnosis, but there's perhaps a written formulation, like helping the parent and the child understand what problems they have, why that might be a problem, the things that might be useful for them. Some areas are running groups either for parents or for young people with some of those sorts of difficulties, as well as recommendations for schools, because I think getting the adaptions right in school is often vital.
I love those ideas though. That's like really developing someone's education as to why they are feeling the way they feel, which is exactly what you want them to do going into adulthood.
Yeah,
so
absolutely.
That's really helpful.
Yeah.
That's great. So one of the things we hear a lot on the ground and from feedback from parents is there's a lot of waiting to get into CAMHS or waiting for assessments to hit a threshold or a criteria for CAMHS. What interventions are available or accessible for people whilst they're waiting or in that situation?
I think in the last 4 or 5 years there has been an expansion and investment in provision of services for the milder to moderate end in terms of kind of mental health for young people. So a lot of the CAMHS services now work in that moderate to severe end in terms of mental health difficulties, and there's quite a lot of work happening in the voluntary sector that will provide more of that early intervention offer, as well as a big government funded initiative in the last few years has been mental health support teams in schools. So these are practitioners that receive certain training to deliver, again, that mild to moderate end of mental health. So they might be doing brief short-term focused one-to-one sessions in classrooms with young people who've been identified with anxiety problems or OCD, but perhaps earlier on in their journey. They're running groups in schools now. There's a range of things that seem to be really effective, and a big part of that model as well has been really aligning the workforce to the evidence base. So for these sorts of difficulties on that milder end of the spectrum, what interventions are going to be useful. Some of those are going to be CBT based, so investing in developing a CBT workforce specifically for young people. And the government did roll out, there were several tranches of funding that came out over the last few years in quite a lot of areas, and I think they're in up to about 50% of systems or 50% of regions now have mental health support teams in their schools, which is really great because I think it's taken some pressure off the CAMHS services who are dealing with a more moderate to severe end. I think some of the difficulties come in terms of that flow, like where do young people get picked up, who's suitable for what if they don't get better after a brief intervention, do they then have to wait for a CAMHS intervention? And unfortunately in most areas they do. I think though some of the mental health support teams in schools have been quite creative with the resources they've been using. So we've seen some good examples where they're employing different digital products, often gaming type products that young people like using. There's a good one around AG that I've seen work well with some good evidence coming out, and also different tools to supplement in between sessions. So a young person might be coming to a group once a week, but what else can they do between, because there's another 7 days in the rest of the week and many hours. So what use of digital products might they have in between? And there's been quite good uptake in some of those areas in their school-based programmes around those products, which I think are really useful. And actually if young people are accessing treatment more quickly, they're less likely to deteriorate and for something to turn into a more severe problem. So it goes back to the point we were making earlier around getting the right support at the right time, and we know so often young people are waiting a really long time before they can get support. So I think generally the mental health support teams in schools has been a really good option, and thinking outside the box with what could be offered.
One of the things that we're offering is groups in schools with some ICBT that sits alongside it really. But one of the things that we have feedback about quite regularly is that the children receiving it recognise the symptoms more quickly because they're in a school setting, and we're delivering the groups online, so it's all very safe. But they can identify the symptoms and then go and ask questions, and that then leads into additional support and help, which probably might not have presented itself until a year later or whatever before. So and
I think that's a really good point. Having been involved in quite a lot of transformation work of systems around how we deliver care, we're not often good enough at asking young people what they want or what they think would be helpful. I think using people with lived experience can be really vital for getting people to explain what would have been helpful and what's your journey been like and what could have been different. People often got brilliant ideas and really good insight about their symptoms and where things did start to change for them in a positive or a negative way. So I think the more that we're really bringing lived experience in, like to an early phase, whether we're developing products or developing or redesigning our services, I think it's really important. And the same for parents, like they're there every day as a parent or carer. Your young person really well. How are we actually engaging them in designing our services or our product?
And that goes back to our earlier point as well about the single point of access, getting feedback from the parents who have made those 15 phone calls and are getting nowhere, and getting their feedback as to how it could be better. So could you tell us a little bit about how the ICB landscape has been changing over the last few years and what impact that may have had?
There's been significant change, hasn't there, in the last 12 months in terms of several years ago, quite a few years ago now, we had CCGs evolve into ICBs, or integrated care boards, and where powers devolved up into regional or county level often. And we're seeing in the 12 months with the political situation changing that ICBs are going to be significantly reducing in terms of workforce numbers, but also I've really seen a shift in the commissioning relationship that impacts in terms of how services are designed or how they're funded, how they're contracted. And actually, in previous times, commissioners sitting in the ICB would very much be decision makers and were there to oversee the delivery of children's mental health services and ensure performance was really high. And actually what I'm noticing on the ground now is that accountability really sits with the provider, so the organisations delivering mental health services, to ensure that they are meeting their key performance indicators, looking at quality. Not to say those things weren't being looked at, but it's who's leading on that oversight has really shifted. And I think there is some paralysis in parts of the system because it's unclear how the ICBs are exactly going to evolve, and it's really difficult for staff in those roles. But on the ground then, there's still a lot of CAMHS services that are trying to transform as we speak. They're trying to do different, they're trying to improve, and that does become complicated if it's not entirely clear who's the decision maker, who can sign off on redesign plans, for example, or who's making funding decisions. And there has been quite a shift with some of that falling more to what I'd say provider space, so back into perhaps the NHS trust, and what the actual teams need themselves. Well, they want to reduce their waiting lists, and they need more staff, and they want products that they can use, or tools that they can use, or groups that they can run while people are waiting. There's still a job to be done and a lot of young people waiting for support. So I think trying to really stay focused on what are the things that can make a difference to our waiting times, to the young people that we're treating, how can we improve their outcomes, has been really important, so we don't get too stuck in that wider system that is evolving, whilst that's just juxtaposed with there is much more of a system approach to redesigning services now. So actually the NHS service on its own isn't probably providing care, it is working really closely with the local authority, it is expected to work closely with schools, as we're saying about mental health support teams in schools. So we really do want that system approach to delivering care. But it's complex when you've got a wider system that's evolving and decision making is moving and nobody's still entirely sure where that's going to end up. But it does risk affecting care if we can't stay really focused.
How do you think it will impact the interventions that may be available or delivered, having that change of shift at the top of the ICBs?
There's part of me that hopes there's part of me that hopes it becomes simpler to make decisions, because I think what strong leaders in those services want is they want workforce with the right skills based on the evidence base. They want products with an evidence base to say that this is worth me investing in this product because we know that it's going to help young people get better, or it's going to help inform parents and improve their skills they've got with their child. So hopefully if it makes decision making faster, that's only but a good thing for the young people and the families involved. But I do see the level of autonomy varies by system level. So I think we need to wait and see how it pans out.
So I understand some of the national KPIs are changing, and we're going to be focusing more on completion rates for clinicians. Could you tell us a bit more about what that is, what that would look like?
So historically in CAMHS services, at least, there was a big focus on the number of people accessing a service, and actually we saw it as well in the adult services in the NHS talking therapy space. Whereas in the last couple of years there's been much more of a focus on, it's not just how many people come into your service, but how many people are actually accessing completing a course of treatment. So they are starting to monitor completion rates and the number of clinical contacts, for example, a clinician is making, trying to drive those sorts of things up. And I think there's something here around how do we support the workforce with that shift. Certainly those that have been around NHS talking therapy service, we know from the start there's a big culture on focusing on job plans and how many contacts per week a clinician has to offer.
So we understand that the national KPIs will be changing for how services are going to be measured. So moving more towards a completed treatment episode of care type of model. Could you tell us a bit more about what that will look like? And
it's been a really interesting shift in the last year or two. So children's services and adults, actually, if we look at the NHS talking therapies model, were very much always modelled on how many children, young people, or how many adult access the service and come through your front door, and the waiting time was always focused, or a big target was around the waiting time from referral into that first assessment. Now, what wasn't very good about that focus was there would then be a huge amount of, whether it's adults in your adult service or children in your CAMHS service, who were then stuck waiting on treatment. And what our data wasn't really illustrating was the sheer volume of people waiting to start a course of treatment. That has really shifted in the last couple of years, and we saw it first in adult services in NHS talking therapies, and now we are seeing that come into CAMHS, with a big focus on not only the access rate at the front door, but how many young people are completing a course of treatment. And they are focusing on how many drop out and the percentage which complete a course of treatment, which I think is vital for the young person, because that's why they've come into treatment, right? It's to get a course of treatment. What's interesting when you look at the data in a lot of CAMHS services is the number of contacts per clinician is actually quite low. That doesn't mean clinicians, by the way, are sitting around doing nothing, not at all. But I think it does reflect the level of complexity and casework that goes into managing a lot of these cases, and the amount of phone calls and school liaison and parent liaison and social care liaison, which takes up a huge amount of time, and then you need to record that on a system, which is really burdensome time-wise. So there's also a national driver on better understanding clinical contacts per clinician at a service level and driving those numbers up. Because as a clinician myself, I think we all buy into the idea I want to be doing as much face-to-face or online time with that young person rather than sitting behind my computer screen typing up notes. But I think it is a culture shift for clinicians, having been in some services, having these conversations with clinicians about how do you see more young people. And initially that's a really scary conversation because they're already really busy and pretty burnt out actually. So very rarely do you meet people who are sitting around with time on their hands. But I think it's the way that they're working needs to shift. So whether that's clinical systems that are much smarter, much more efficient to use, whether that's tools that they're using to deliver treatment or to do work alongside their therapy sessions, perhaps homework tools that the young person or the parent can be using in between sessions, that's perhaps more likely to help both engagement, but actually whether the young person, their symptoms improve. So I think it's about trying to work smarter and perhaps be broader in terms of the things that we bring into our treatment plans, rather than it just being about that one-to-one face-to-face session with that young person or their parent, but actually what else in addition to that can we do to enhance the treatment and the efficacy. I think there's some real opportunities there.
It takes it away from being a one session in a week, in a 7-day week, which is very isolated. into being an integrated part of that child's life, where you can work alongside it, be in the home, it can be online, it can be at school, it can be everywhere.
And we know that, again, if you speak to young people and ask them their opinions, they're quite a heterogeneous group. Actually, some young people, as a lot of people think, all young people want to work online. And some do, and yes, they're on their phones a lot, and some really do like to work in that way, but some do want face-to-face, or some do want a gaming package, or some do want to see somebody at school once a week. So I think having a number of different things that you can offer as part of that treatment is really important. And the same for parents. Some parents will really value being in a group or a support group amongst parents with other ADHD children. Some parents might want to work on their own and feel very shy and unconfident to talk in a group environment. So I think having a range of options for different needs is really important.
Can I ask, in relation to that, how social media plays into that work, like when you're working online from a therapy point of view, but also where a lot of the interventions might also be online, how we could reassure people that it's not a social media link, and maybe what you're hearing about social media from your work that you've done?
I think it's a minefield, isn't it? Social media. Certainly, I see in my own practice with young people, social media can have a massive effect on certain types of symptoms and problems for a young person. I think particularly if it's really unfiltered access to anything and everything. And young people are clever, right? They find all sorts of things that we didn't think they'd go looking for, or it's a real challenge to monitor social media use. And certainly it's something often picking up when I'm formulating with a young person what is happening in terms of their actual difficulties. You can sometimes pull out the role of social media, perhaps in reassurance seeking, or they might be doom scrolling what their intrusive thoughts might be. And now a little bit psychoed is quite helpful, but actually if they're endlessly checking up and double checking and triple checking things, and that's because they have health anxiety, or I say like an OCD intrusive thought, actually that's not very helpful to spend lots and lots of time looking at those things. So I think perhaps the role of parents, not putting it on parents, but as a parent I can say that, like how, to what extent you understand your child's social media use, to what extent you manage the time that they're on it, to what extent are they doing other things outside of sitting on their phone in their bedroom or on their tablet, I think is really important. Because there's both good and bad. I don't really know for the research, actually there's a ton of really effective digital programs coming online that have got really strong evidence base that they work, young people are really engaged in them, the outcomes are really strong. But actually if you look at generic apps around mental health and wellbeing, actually there's not strong efficacy often. But it's about what's in the program, what is it doing, and how much do I know about my child and what they're accessing and why.
Going back to the evidence base.
100%. And also the evidence base on how that young person wants to interact, asking them what do they want and how do they learn best, or how do they open up best.